Good morning and welcome to our Mailman School Public Health event, Monkeypox and Protecting Communities of Color. My name is Linda Freed and I have the honor of serving as the Dean here at Columbia's Mailman School. And it's my really great pleasure to welcome you here today. As many of you know, the Mailman School Public Health has been celebrating its centennial over the last academic year. We are deeply proud of all this school has done to contribute to a remarkable century of progress for the public's health. And we're continuously focused on meeting the challenges of this second century of public health. This, of course, includes ensuring that populations are protected against and prepared for the next epidemic and for multiple simultaneous epidemics, which are increasingly likely. Throughout public health history, we've seen that communities of color are among those hardest hit and most disproportionately affected by infectious disease epidemics. We saw this, of course, with HIV and AIDS, and we are still seeing this with COVID-19. And this year, we see these disparities with monkeypox. Monkeypox cases rose dramatically in the United States in June and July. At the end of July, the U.S. had the most cases of any country and declared monkeypox a public health emergency soon after. Since then, cases have peaked and slowed, but the racial disparity in monkeypox cases between Black, Hispanic, and white communities has remained large. Together, Black and Hispanic Americans account for over 60% of monkeypox cases, despite only representing 12% and 19% of the American population, respectively. On the prevention side, monkeypox vaccine distribution began at the end of June. However, Black and Hispanic communities account for only 1/3 of vaccinations against monkeypox to date. So today, I am really pleased to convene this impressive group of experts and to welcome you to a conversation in which we will discuss how in public health we can better protect communities of color and all of us during this current epidemic and future ones alike. My colleague, Dr. Wafa El-Sadr, will moderate today's conversation. Wafa is an international expert in infectious diseases, pandemic preparedness and response, and the public's health, and has advocated for communities most impacted by HIV and led solutions for over 4 decades. She is Executive Vice President of Columbia Global, a university professor of epidemiology and medicine, and the Matilda Krim Amfar Chair of Global Health. She's the founder and director of ICAP and leads the New York City Pandemic Response Institute. Wafa, I'm honored to turn the discussion today over to you, and thank you.
Thank you very much, Dean Freed. It's a great pleasure to have the opportunity to moderate the conversation today with such a wonderful panelists and speakers. So before we get started with the presentation, I'd like to briefly introduce our speakers and panelists today. I'm going to start first by introducing Deborah Fraser-Howes, and she has given me permission to call her Deborah. We've known each other for now almost 40 years, Deborah, so we go back a long way. And just to give you a snapshot of Deborah's illustrious career, she is the founder and president of Choose Healthy Life. She has been widely recognized for now more than 4 decades, in fact, for her global leadership and her commitment to communities of color, in terms of issues like HIV, AIDS epidemic, teen pregnancy, social welfare, and many, many, many other issues. She has advised 2 presidents while serving on the President's Advisory Council for HIV/AIDS from 1995 to 2001, and she's been also served as vice chair of the HIV Human Services Planning Council in New York City and chaired the National Institutes of Health Public Education Technology Committee. Now, I know Deborah from way back because she was the founder and is the founder of the National Black Leadership Commission on AIDS. And she established this as a model of an organization that's committed to the health of communities of color and worked diligently in establishing relationships with the Black church to address the HIV epidemic then in the Black community. And this model that she established way back when she founded the National Black Leadership Commission on AIDS is the same and similar to the way in which she has conceptualized and is leading now the Choose Healthy Life initiative. So welcome, Deborah. It's a great
Thank you
honor
so
and
much.
pleasure to have you with us today.
Thank you, Rafa. Thank you so much for having me.
And then I'm going to move next to introducing Dr. Dimitri Daskalakis. Dimitri is another individual that I have known for many, many years, a renowned infectious disease expert and a physician who is currently serving as Deputy Coordinator of the White House National Monkeypox Response. He works very closely with Robert Fenton, who's the coordinator of the White House National Monkeypox Response. And he's leading the coordination across different agencies to control monkeypox outbreak in our country at this point in time. Now, prior to his appointment, Dimitri has served in New York City, as well as also nationally at the CDC in a variety of roles. He was the Deputy Commissioner of Disease Control, New York City Department of Health and Mental Hygiene. And he also served as the Director of the Division of HIV Prevention at the CDC. I have to say that Dimitri is one individual that is always, in my mind, bring remarkable expertise in terms of content, in terms of the science, HIV prevention, as well as, of course, in infectious disease overall. And he's one of those individuals that is distinguished by his commitment to innovation, to anchoring the response in science, but also a deep commitment to equity and achieving an equitable response to these global health threats. He's an activist physician with a focus on LGBTQ+ communities. He's also served as well in a variety of leadership roles, for example, being the incident commander during a measles outbreak and also during the COVID-19 pandemic here at the New York City Department of Health and Mental Hygiene. So welcome, Dimitri. It's really a pleasure and an honor to have you with us and to particularly to address the topic of today's webinar. I'm going to hand it over to you and you will provide the presentation and update on where we're at in terms of the monkeypox outbreak in this country and in terms of the response. Thank you.
Thank you, Dr. Alsader. Thanks, Wafa. Really excited to be on the same panel with Deborah. So really, this is a family affair, as it were. So thank you so much, and thanks, Dean, for hosting us here as well. So I'll just start. Before I go here, I just want to acknowledge sort of for all of us, just the awful gun violence that is happening in the U.S. and how it's affecting LGBTQ people and people of color across the board. So just before I start, I wanted to just acknowledge sort of the energy that is needed to fight off hate with love. And that really, I think, frames a lot of what a good outbreak response also looks like, which is really identifying a way to end outbreaks using love and respect for the communities that you serve. Before I start the slides, I'll say that I've worked in lots of outbreaks, whether they're chronic or acute, and there are three ingredients or three parts of the formula that are necessary to be able to achieve outbreak control. And I think Wafa already mentioned science. So it's important to have science and to accelerate science in an innovative way to address the needs of an outbreak, especially in communities. The second is that community engagement with a focus on equity. So really acknowledging that outbreaks always tend to go in a direction that is not equitable. So really thinking from the beginning of ways that you can intentionally address this. And then finally, political will, which really means identifying ways where policy and folks who make policy and support policy are able to move things forward in a way so that science and community engagement can blend with policy and political will to accelerate the end of an outbreak. Next slide, please. So we're going to talk about Mpox specifically, and I'm going to give you a situation update. So as of November 21st, there have been over 29,000 cases reported in the United States. You can see on this map, areas with darker blue represent jurisdictions that have a higher case count. This is what the epi curve looks like, the epidemic curve for this outbreak. And again, for those of you who don't see these very frequently, remember that the bars represent cases reported on a day, and the solid line is a smoothed out 7-day average that takes into account the variability that you see in case reporting that we see very often in infectious diseases. And also, when you look at this and you were to measure the peak at the really beginning of August, mid-August, to currently, we're over 95% reduction in the number of cases that we're seeing in the US. Again, remembering that we are seeing warm spots that are contributing most of the cases to the case count. Next slide, please. So the heterogeneity in the case count is also reflected in some heterogeneity that can be seen in the demographics, both nationally and locally. I'll start by taking a view of what we're seeing from the perspective of age and gender identity. So this graphic available on the CDC website for MPOX shows you that the majority of cases are happening in a sort of 30-ish range of age. 95.5% of the cases are among cisgender men. A little bit under 3% are in cisgender women. And then we have transgender folks who are who have about just a little bit shy of 2% of the cases have been attributed to people who are either transgender or who report gender or sexual orientation other than the ones that we have listed, or sorry, sex of birth other than we have listed. Next slide, please. This is a graphic that shows you what's happened over time to the demographics looking at race ethnicity among cases. So if you were to just squint and look at this graphic across the entire outbreak, the left is the beginning, the right is where we are today, you'll see that those purple and green bars seem to have taken over the height of this stacked bar graph. And so the green represent Latino individuals and the purple bar are Black individuals. So what that means is, like so many other outbreaks, whether chronic or acute that we're seeing, so we heard about COVID and HIV, this is concentrating in Black and brown populations. There is some heterogeneity across the country. So in some areas, it is happening more frequently in Black folk, and in other areas more frequently in Latino folk, but the trend is pretty much consistent across the board. So the case counts are decreasing, but still too many Black and brown people are being represented in the cases that are happening. So again, as Mary Bassett said, one of my mentors in New York City, the best way to address equity in outbreak is to end it. So that's the route that we're on, but we need to end it equitably, really sort of focusing on all populations to make sure that we bring it to an end without concentration in one pop. Next slide, please. And also there are data that are available, at least through October 21st, that show really what's happening in terms of sexual activity and actually MPOX transmission. And so the most notable thing about the slide is not just that still recent partners exclusively men by men continues to be the largest bar, it's that the largest bar is in fact missing data. And so when you're looking at public health, I think one of the important lessons is what can we do to improve data systems? Specifically, how can we improve race, ethnicity, and sexual orientation and gender identity? Because as that orange bar gets bigger, we can say less and less about what we know about transmission in this country. Next slide, please. Now I'm going to move from cases and talk about treatment. So there is an experimental drug that is being used to treat MPOX. It's called tecovirimat or TPOXX. These are the data that show the demographics of individuals who have gotten the TPOXX drug through a CDC expanded access investigational new drug pathway. And so what you can see is that this bar graph really reflects very closely the bar graph that I showed you before in terms of where the cases are. So again, the majority are somewhere in that 31 to 35 range. The majority are cisgender men, and you can see sort of cis women and transgender folks are a smaller sliver, but really seem to reflect what we're seeing in the outbreak. Next slide, please. Similarly, the race and ethnicity of individuals who are being treated through this expanded access opportunity more closely approximates the race ethnicity of individuals who are being measured in case count. There is a disparity that you can see, which is that yellow bar, which represents Black individuals, is a little bit smaller than it should be compared to the number of cases Black individuals represent. This disparity is present, but it's actually smaller than the disparity I'm going to talk about next, which is vaccine. Next slide. So there was a supply and demand mismatch at the beginning of the Mpox outbreak, primarily because this is an unprecedented outbreak. And so it didn't move the way Mpox outbreak would be expected. And so really an important shift had to happen from looking at sort of ring vaccination post-exposure strategies to pre-exposure prophylaxis strategies. We had to do a lot of work to increase vaccine supply, and that included moving from subcutaneous dosing to intradermal, in effect increasing vaccine supply by fourfold, and also work offshore and onshore to increase production of the vaccine. We are in a very different environment with adequate vaccine supply currently. Over 1 million shots have been administered to people in the United States, but the graph will show you that we have a softening of the demand in first and second doses. And also, I think, also a need to stimulate, ongoing conversations about vaccine availability and who qualifies for vaccine. I'm going to share with you that there are disparities that we're seeing in vaccine administration, but there has been some progress. So compared to the beginning of the outbreak to current, there's been about a 23% increase in Latino individuals getting vaccine, and there's been about a doubling of Latino individuals accessing vaccine, and a similar in Black individuals. So we're seeing a trajectory, but it's still a mismatch that we need to address. Also, it's important to remember Mpox does not live in isolation. It is a virus that exists in interacting epidemics. We have data from the MMWR published September 9th, looking at multiple jurisdictions. 38% of people who were diagnosed with Mpox also had HIV. 61% either had HIV or an STI. These interacting epidemics, supported by social determinants of health that make it harder for people to access service and also potentiate the severity of disease, come together in something that we call a syndemic. So this monkeypox, this Mpox outbreak exists within systems, a syndemic of HIV, STI, as well as the social determinants that support its poor outcome. Next slide, please. And that really plays out in the data that we've seen. So people with Mpox and HIV seem to have more severe symptoms. They also tend to be hospitalized more frequently. So 8% versus 3%, people living with HIV versus those without. But a deeper dive shows that people who had less well-controlled HIV were way more likely to be hospitalized, and so were individuals with lower T cell count. So fold time greater in hospitalizations based on control of their HIV. Next slide, please. And that played out even further with data that showed that severe monkeypox in hospitalized patients, so the case series of cases reported to CDC, HIV and other immunocompromised strongly mapped to this. 82% of the 57 severe cases that CDC was consulted on had HIV. For those of you who do HIV public health or care, this should make your blood run cold. 72% had a CD4 count of less than 50. So that is really very end stage HIV. Only 9% of them were on HIV meds at the time of their diagnosis. And in syndemic style, racism and other social determinants like homelessness come together to show that 68% of these severe cases were Black and 23% were homeless. Next slide, please. So programmatically, to address this, a lot of work happened to focus on ways that flexibilities could be created so that HIV and STI, as well as mental health resources, could be leveraged during the Mpox outbreak to move forward monkeypox-specific or Mpox-specific work. Additionally, beyond disease-specific strategies, housing was also leveraged to identify ways that we could address that social determinant of health to move forward on the MPOX work and address that synergistic epidemic that is potentiated by social determinants that lead to bad outcomes. Next slide, please. And a lot of the work that's happened focusing on MPOX really had to do about messaging. And so I think there are important lessons we learned from HIV and STI. One of the most important was that when MPOX started, we were not going to replace gay-related immunodeficiency. So we learned lessons from 40 years ago to make sure that we really focus on strategies to let people know what exposures increase their risk without pinning a virus onto one population or community. To do that, we then had to make sure that we did harder work, which is to then leverage vast networks of partners to make sure that the word got out. And those include not only community-based organizations, faith-based organizations, as well as clinicians were key. Next slide, please. And being intentional about not creating stigma is really critical. So the messaging that anyone can get monkeypox, but where we're seeing it the most is in certain communities, is a lot different than saying Mpox is a virus of this community. And so that was very intentional, with actually language coming on from the very beginning from governmental public health to set the bar for how those communications should happen. So again, that is a responsibility of governmental public health, which is to provide information in a way that the trusted messengers can use and magnify the words to the right people, specifically in this scenario, gay, bisexual, other men who have sex with men, and transgender individuals. Next slide, please. We did that in lots of ways, so including using some very atypical strategies for communication, which are atypical to everyone except for those of us who do HIV and STI work, which is to make sure that we connected to trusted messengers and trusted platforms. And sometimes those platforms included social media platforms, dating apps, et cetera, to really get the sort of exposure-based information to the right people so that we could accelerate the right behavior change as well as the right access to vaccination services so important to end this outbreak. Next slide, please. And that also means taking another lesson from the HIV playbook, which is even without having a perfect amount of data or perfect data, really providing good guidance around how people can keep themselves safe so they could make informed choices. This is a harm reduction stance. So rather than being absolute about do not do this, it's here's what we recommend in terms of where you are, and please meet us to the point that makes sense for your life. As data increased, we were able to be more definitive, and that's a part of really important risk messaging, which is what we know today may be different than what we know tomorrow, but please follow along with us in our communication so we can give you the best strategies to stay safe in a way that's frank, speaks language that people understand, and exists without shame or judgment by recognizing people's lived experiences. Next slide, please. And I'll just say that part of what we also did was make sure, again, that we realized that governmental public health and public health in general isn't the voice that everyone listens to. So really looking at ways that we could provide resources for trusted messengers to get the word out. So we use an example of a drag race drag queen, Shea Coulee, who put out a message, and just it got so much more attention than so many of the things that we did just sort of from regular government public health channels. So really that collaboration with community is key. Next slide, please. And also the engagement is important. So we convened at the White House over 500 engagements, including engagement with a workshop that focuses on LGBTQ people of color to really help us understand better how we could address the outbreak and response. And I'm showing pictures of Kay Hayes, who some of you may know, who is our equity lead for the MPOX national response, and Admiral Levine, who has just been amazing in terms of our linkage to population. Next slide, please. And we heard it loud and clear. So we heard that risk assessment was getting in the way of vaccination. So CDC removed the requirement for a risk assessment. So you don't have to check a box and say that I'm a transgender woman who has multiple sex partners to get vaccine. Wanting vaccine is enough. We also heard that where the vaccines were given, because of the possibility of a spot that can last several weeks after the vaccine that's visible, was getting in the way, literally stigmatizing people with a mark. And so we were able to recite where vaccines could be given on the back and shoulder, places that clothes generally cover, in response exactly to what we heard from the community. Next slide, please. And it also became really important as vaccine supply increased to make sure that we were reaching deeper into the population. And that includes LGBTQ folks. We changed the stance from a post-exposure stance to a pre-exposure prophylaxis stance, increasing the circle of individuals who could qualify, not only based on their experience in the last 6 months, also based on their potential future experience. And also importantly in this document, we're also able to shout out commercial sex workers as a really important group that we needed to make sure that we reached for vaccine and other prevention messages. Next slide, please. And in terms of equity, a very important lesson that I think we all know and have learned is that if you build it, they don't always come. And so what tends to be a better strategy is to really identify ways that you can bring intervention to the community as opposed to expecting the community to come to you. There are other funding opportunities that really do this, but I'm going to highlight a couple of these equity interventions that happen through vaccine distribution. One of the examples that we bring up is Atlanta Black Pride, where we deployed about 5,000 vaccines. 4,200 vaccines were done, and those vaccines, 70% were in people of color, about 50% were in Black individuals. Again, really supporting something that we know, a public health lesson that's so important that we've learned from so many experiences, that if you bring things closer to the community in a way that they want it, they tend to take you up on it. So really important lessons for MPOX and beyond. Next slide, please. That brings me to the end, and I'm going to hand it back over to Wafa, so we can continue this exciting conversation. Thanks, Wafa.
Well, thank you very much, Dimitri, for a superb presentation. And Deborah, if you can please turn on your video, that'd be wonderful. Thank you. I think what I'd like to do is to start a conversation with Deborah first, and then get to you, Dimitri. But I also want to invite all of our audience to please put your questions in the Q&A box, and we'll try to get to as many of them as possible. But maybe, Deborah, starting with you, I wonder if you can describe in brief, your motivation for establishing Choose Healthy Life, and how you see the engagement of the organization with MPOX outbreak in particular.
Well, Wafa, thank you very much. I saw in my community, I retired from corporate America. I retired from the National Black Leadership Commission on AIDS. And in corporate America, I did diagnostics where we put forward the first HIV test over the counter, first Ebola test, first rapid hepatitis C test. So as I come out of that in retirement, I'm actually sitting watching Black bodies being put into Black bags in the back of Black refrigerator trucks. And I'm saying to myself, here we go again. Not acceptable. We can't, this is not normal, and we will not do this. So I immediately reached out to Black pastors, the late Reverend Kavanaugh, but unfortunately, he just passed away last month, and Reverend Al Sharpton, and told them that I needed them to come together so that we could develop a plan and a group of ministers that would really be able to shape policy and move things for the community on the COVID response. So it was COVID that moved me. It was so much like HIV and AIDS. There was all this misinformation out there. The government seemed to be hostile. Nobody knew the truth about who was getting it, how they didn't have data on people of color. People of color were dying. We knew that because the ministers were burying them. And the fear again, which was the same thing that happened with HIV and AIDS. So we brought these ministers to the table and developed a plan of action that was very similar to what we did in HIV and AIDS. In AIDS, we developed 17 affiliates across the country, all headed by Black clergy, to ensure that resources went into communities of color around HIV and AIDS, when a lot of people were not really concerned about what HIV and AIDS looked like in the Black and Latino community. So here we were again with this really serious, deadly situation. And I am a firm believer that we are the people that we've been looking for. and that we do have the resources and the knowledge base to move things forward. And bringing these folks together, we set out, determined to go out and get funding to resource the Black church. We had 60 Black churches in 5 cities, and then we grew to 120 Black churches in 13 states. We got money from HRSA, we got money, private money, we gave and a partnership with Quest Diagnostics so that there would be testing, first of all, because we were in testing deserts, and we would have vaccines when we pivoted to the vaccines. We are now pivoting to health because we realized that much of the death rate because of COVID came about as a result of pre-existing conditions. So we keep talking about health disparities, and now we've changed the language to equity, but we've still done nothing about it. You know, equity and health disparities, it's the same thing. It's been decades that we've been dealing with these issues. So we decided that this is how we were going to respond. And we actually put health navigators in each of these churches reporting directly to the pastors. And they set up these pop-up vaccination sites in the church. Now, just the other day, we had 90 ministers and staff on with Dimitri talking about monkeypox, because the ministers want to know what's going on. The thought that there are no Black gay men in the Black church is ridiculous. So the idea that these ministers, this group at Choose Healthy Life, is moving forward, not waiting for a response to come to them, but they're moving forward to seek a solution and to put information in their churches. So what we're going to do is we've already had a follow-up meeting. They're going to be talking about monkeypox on Sundays. They've connected with local federally qualified health centers and other health places so that they can connect their parishioners and the people in the community to come to the church, because church is not just on Sunday. And they're going to connect them to the health care that they need. They're going to make a plea to the people in the church and to the women, because, you know, every time men get infected, women get infected. So we're going to make a plea also to the women in the church that if they think that they're at risk, please go get tested, and please go get vaccinated. So these are the things that we're doing, in the way we're responding to monkeypox, as we responded to AIDS, as we responded to COVID-19.
Thank you. That's wonderful. And you're right. I mean, there's so many lessons learned. And I think it's, I always say there's no need to reinvent the wheel. We tend to try to reinvent the wheel, and we lose time and we lose momentum and we lose people in the process.
Yes.
So
Yes.
thank you. Dimitri, turning to you, and Deborah mentioned the pivoting to health. And I know you have been an advocate of thinking differently about sexual health. And you mentioned the syndemics and the whole issue of HIV, STIs, Mpox, and so on. Can you share some of your thoughts regarding trying to transform the STD paradigm to sexual health paradigm? You're muted, Dimitri. We can't hear you. No.
Now you can hear me.
Yes.
Perfect. Thank you. Sorry about that. Double muted for some reason. So no, thank you for the question, and thanks, Deborah. So I think that in general, you know, I think outbreak response is a weird time to talk about it, but it's actually the right time to talk about it too, which is that, you know, a strategy that's based on pathology tends not to attract people, and a strategy that's based on, you know, the word risk sometimes is pretty aversive. So I think that really strategies that really support the health of an individual and a population or community, rather than focus just on a single disease, tends to be a pretty important strategy to move forward work. And so I think, you know, in the Mpox outbreak, I feel like there is some really important, I guess they are kind of lessons, but they're exactly pulled from the playbook of STI and HIV, which is that nothing sort of lives in isolation. And so like the lessons that we're learning of trying to sort of remove the schism really between HIV and STI, I think played out in Fast Forward with Mpox, which is what happens if we acknowledge from the beginning that this is something that lives in a syndemic, that lives with these other infections. And what if we leverage the resources? So I think it's no accident that the people that are doing so much of the MPOX work are coming from the HIV and STD space. And so I think that that sort of is also part of the continuum of sort of the strategy of really focusing on health. So supporting, one of my favorite doctors, Charlene Flash from Houston, used to say to me, Dimitri, when you say risk, remember that your idea of Risky Friday is someone else's idea of a really good time. And so just remember that what you're doing is creating this sort of us and them. And so really strategies that support health in a way that is intentionally not stigmatizing and focusing on really a harm reduction strategy for addressing infectious disease risk in the context of behavior is really, I think, the way that we get to what we need. I think it works for sexual health and STIs. It works in contraception. It works in diabetes and diet. You can just go down the list of how it really interacts.
Yes,
Right.
and Wafa,
Yeah.
one of the things that we've decided to do in relationship with Quest Diagnostic is to offer a full panel of tests to everybody who wants it in the church and around the church. It's going to tell them what what the numbers are around diabetes and liver health and kidney health and all of the things. We're taking their blood, using it to give them back the power to deal with their own health, so they don't find themselves on the end of a ventilator when the next pandemic hits. We also do believe that we have to draw a line in the sand in regard to resourcing the community to do it, because we've seen what it took to resource the community, and it wasn't much. And we've seen what we did around it. We vaccinated over 100,000 people in 9 months. These were the hard to vaccinate people. So Dimitri is right on all those fronts and pulling this through. The other thing is, people keep saying, when are we going back to normal with all of this, all of these pandemics? And then the issue is that we can't go back to normal because we died in. So we have to go to something else. And I think one of the blessings that we have is that we have the Malman School of Public Health. We have a Dimitri who's at the White House and at CDC. We have you. We have Choose Healthy Life and some of the other programs, like the program in Philadelphia where the Black doctors took money out of their pocket and just went out and tested everybody on every corner. There's an innovation that went on during COVID that's also we're going to see going on during monkeypox. We're using those same innovations, and it is those innovations that need to be brought to the table. The community needs to be able to sit at the table to do some of the advising. We shouldn't just be told what's happening to us, but we should, the old adage is that if you're not at the table, you can expect to be on the menu. So they need to be at the table so that they can advocate for what their community needs, and they also need to be listened to, because they know more about community than most of the public health establishment knows. I really urge the public health community, and I know that Malman teaches this because I'm on the board of Malman, and I know that Dean Freed is committed to this. But I really urge everybody to reach out to community. Don't create these solutions in a silo. But reach out to the community, because the community is already distrustful about what happens if you allow them to develop their community infrastructure to work along with public health infrastructure, to work along with medical infrastructure. We would be so much further along in all of the things that we have to do. And thank God that, the people that are on this call realize that we can get more people to realize that and come on over with us. I think that we're going to be in a good place.
Great, thank
Wafa,
you.
do you mind if I just add to that to Deborah's amazing comment, which is also, the HIV, STD, like this mental health housing system keeps the system warm for when you have to respond to an acute challenge. And the same is true for strategies that maintain infrastructure in the community. I think Deborah will agree that and I don't think that we have a adequate answer for
Yeah.
how you can maintain infrastructure across both sort of public health infrastructure as well as like that community infrastructure that's so critical. But I feel like MPOX as a case study, I think, shows that
Yeah.
when you are able to leverage those things, even in the lack of perfect data and the lack of perfect resources, you're able to accelerate a decline in an outbreak.
Yeah,
Absolutely.
and I think in many ways, I think that's where the whole, the whole idea of preparedness. We shouldn't wait till the crisis and then kind of try to rally to respond to a crisis. And in many ways, this is something that we're really focusing on at the New York City Pandemic Response Institute. Is the two things. One is the primacy of preparedness, and then the second is, of course, the meaningful engagement of communities, on an ongoing basis, not just during the time of a crisis. But maybe going on to another question, and I'll go maybe start with you, Dimitri, and then get to Deborah, is the issue of kind of investment in public health. You mentioned the issue of the data and the import. I mean, the data were very important because they shine the light on the disparity that was happening. And I just want you to talk a bit, Dimitri, about the value of the footwork that public health does, all the way from having the accurate data and making sure it's complete data and so on and so forth, and how that should inform policy and actions.
No, I think it's a great question. And I think one of the things that we've learned through the history of so many outbreaks and epidemics is that people don't really understand what public health does. I think it's important to say that public health is often pretty distinct from healthcare, and that it serves a very specific role that's different. And so I think the first is stewards of the data. And so I think that so much data comes in, whether it's surveillance data through registries or other ways that public health identifies ways to look at data. So that data ends up being what gives us vision. And so if you think about what I presented to you, like the fact that we were able to say, we know the race ethnicity of cases. You also saw what happens when we start to lose data. And I showed you what happens over time. I don't know the sexual orientation and gender identity of some of the people because that data is starting to get softer because it's not getting compiled. So I feel like that's number one, is how can public health be supported to get data that they need, to be able to create analyses that really allow us to see where resources need to go. I think a second important piece of public health is sort of guidance and also the importance of implementation. So it's really the idea that you take the data that you have and you use the systems that you either own because you are local public health or support because you're federal public health, with clear guidance so that public health can be what it tends to be, which is a local event. So really focusing on ways that what's right for you on the ground in New York is not right for you for what's happening in Omaha, Nebraska. But if we provide adequate guidance through public health, it means that those in Omaha and those in New York can implement it in a way that makes sense for their environment. So that's what I tend to see as public health. And I also, I think that the other part that Wafa, that you were talking about is, I think you can see that there's sort of these waves of support for public health. When there's something happening, there's resources that come. And then when the thing is going away or interest goes down, what happens is those resources tend to recede. And then what happens is the infrastructure doesn't exist for the next thing. And then we have to do the thing that we don't want to do, which is build it from scratch again. So it ends up that sort of keeping the system warm and supporting the work in public health ends up being critical, not only for chronic things that we take care of every day, but also the acute things that end up being important for us to pivot on a dime.
Yeah, and to be prepared and have at least the foundation and the infrastructure and the knowledge and the engagement to be able to rapidly respond. Deborah, I'm going to just ask you one question, then we'll go to the audience questions. But you firmly have been in the community, in engaging with the community, in mobilizing community leaders. What do you need when you think about it? What do you need from the government side? What do you need from people like Dimitri and others in terms of enabling this partnership to thrive and for us to get to where we want to get?
I'd like to thank you, Wafa. I want to add something to what Dimitri said about data. Data is critical. Evaluation is also important. And it is important for the community-based organizations, to answer your question, to have these types of evaluations. It's important for us to be able to connect to schools like Malvern School of Public Health, so that we can get the programs evaluated, so we can have that data that proves our success. Because a lot of the Black community and the Latino community does not want to replicate failing programs. It gets us nowhere. And we're very clear on that. So if we can demonstrate success and have partnerships with government and with like the Pandemic Preparedness Institute, these are the kinds of things that we need funded so that they can support the work that's going on in the community. In addition to that, we need the government to cease and desist on episodic funding to agencies. Just, they sort of throw money out there. Dimitri knows this well, and he's not a proponent of this, but they tend to throw money out there because there's an emergency, or because a president or somebody, a secretary of health, decides that this is the disease of the day and I want to address this disease. So they throw lots of money at it, and then when it's something new, they go somewhere else. Meanwhile, the community has built these infrastructures that they should be taking care of so that they can use it, let them build it, let them pivot from whatever that episodic situation is to health, to the other things that need to happen in it, to preparedness. Let them pivot to that so that we are not only ready to do what we have to do with the next pandemic, but we are also, in the meantime, providing connection to care and services to the community. We couldn't get better than that. But getting the government to see that, and not just the federal government, all levels of government,
At all levels.
to see that has been very, very difficult. And if we can turn that around, we would be much further along.
Thank you. I'm going to go now to some of the questions from the audience, and I'll throw two questions, quick questions for you, Dimitri. One is about the the level, the data regarding where cases are reside versus where transmission is happening. That's one question, and then the second question is suggestions for a better word than risk, to use in our daily lexicon in public health, maybe. So two questions for you. Okay, go ahead.
Sure. So I'll start by saying that I think that I think that that really the county level map shows you something really important, which is like with good data flow, you're able to sort of actually use data for actual response elements of work. And so I think the ability to sort of look and say, it's not just this whole state that's glowing, it's these 3 cities that are glowing, really allows us to really target a lot of the resources to where we're seeing transmission. And so I think that this is, again, nothing surprising out of the HIV playbook. Thinking about things like the Ending the HIV Epidemic Initiative, there really looks to say, like, where are the warm spots for HIV, and how can we really work to sort of concentrate extra effort in those areas in a hyper-local way to accelerate the end. Because I'm going to conjure my CDC boss, John O'Merman, and say, when you look at this, like when you really identify where cases are being contributed to the national outbreak, it really helps you understand both what you need to do nationally and what you need to do in a more concentrated way. Public health is key there to be able to see the data. Risk. So I'll tell you that I'll start from an HIV space. So within our division of HIV prevention, we have really changed the language of what we talk, how we use risk. So risk is not a terrible word unless it's defining how someone, if you're saying that someone is a high risk person. So we think that's a problem. But I think that another option is to say that that a person is at risk, that a behavior could put them at risk, that the behavior is a behavior that risks transmission. So I think it's really sort of finishing the sentence. and just making sure that that risk isn't describing a community or a human, but describing either potential exposure. And that, I think, is just good public health practice beyond just HIV and Mpox. Just in general, it just seems as if categorizing someone as risky is not the way to make them your friend, and decide that the interventions that you're trying to give them are for them. People don't see risk in themselves; they see risk in other, and so it really creates a divide that is unnecessary. So, risk is the exposure, not the human. That's a good axiom.
Yeah, and I think that applies to across the board, not just for Mpox, but across the board. I mean, it's interesting that next week is we celebrate or we acknowledge World AIDS Day, December 1st. And here at ICAP, we're planning our usual event, and we've entitled it this year, No One Left Behind, or Leave No One Behind. And it makes me think about what you said, Dimitri, about how do we end it? And in the context of Mpox, which we're focusing on today, and maybe Deborah, you can think about how do we leave no one behind and end this.
You have to get everybody to come to the table, and working with the Black church in HIV and AIDS was not easy. I mean, every Black minister in the country did not want to deal with this issue because of homophobia, drug use, the whole 9 yards. They felt it was safer to stay away from it. Some of them were violently, vehemently against helping certain communities. And the thing was that you don't let, my father used to say, one monkey don't stop no show. You don't let anybody stop an advocate, a real advocate, from moving forward with what is necessary to save the lives of their people, all their people. So looking at leaving no one behind, you take the people with you who want to come with you. There were enough ministers who wanted to come, who saw that they were their brother's keepers and wanted to come and move forward. We created an army around the country with those ministers. Eventually, some of those that were falling on the wayside came, but it's going to take a village to leave no one behind, because we're especially now in this political climate where we're so divided around so many things, we could be moving forward and you won't even know if we're leaving somebody behind, because people are now cowering and hiding because they don't know what to say or what to do and what's politically correct and what is not. If the liberals are going to win, or the right or the left, it's a matter of, we have an opportunity right now in 2 days. It's Thanksgiving. It's time for us and our families, as we are talking around the Thanksgiving table, to put down all the weaponized language and say, listen, here's the deal. We've got monkeypox. We still have HIV and AIDS. We still have COVID. We have polio in New York City sewer water. We've got all of these issues that we have not fixed, and we have to come together and fix them. It's going to take that will and that attitude to do anything about it, anything.
Thank you. And a couple of questions for you, Dimitri, from our audience. One is the issue of Mpox in women. I know there was a recent article that at least described some of the features and the characteristics of the women affected or at risk. And and this is from one of our audience members who is asking in particular about cisgender women, but maybe you can talk in general about Mpox and women overall, both transgender and
yeah, no, I think that's perfect. Thanks, Wapa. So I think that this is one of the sort of important sort of intentional decisions that was made really early on in the communication around this, which was to not start off by saying Mpox is only in gay, bisexual, other men who have sex with men. So starting from the anyone can get Mpox, but we're seeing it in these populations and are reaching to these populations, ends up being really important. And despite that, I think that sometimes people don't include Mpox on their differential diagnoses when they see a woman who has, whether cisgender or transgender, lesions that could be MPOX. So I think that the article I thought was really important to highlight the need to keep MPOX on the list of things, of diseases that may look a certain way. And so I thought that it really added to the literature in reminding us of the population. I think, as you can see domestically, just under 3% of the cases of MPOX have been in women. So that's not an inconsequential number. And so I think a couple of really important things that this reminds me that we need to sort of work toward. And for me, it speaks to the idea that we need to make sure clinicians keep MPOX on their differential diagnosis. But this is the time to advocate for multiplex testing, and this is going to make Deborah's heart fly. So, like, really the idea that when you are thinking about MPOX, it looks like other things. And so do we have an opportunity to move the science forward so that when you see a lesion that looks like herpes or like shingles or like syphilis, what if you had a test that tested for all of those and MPOX? And so you were able to keep it on the differential diagnosis because clinicians are going to be trained that way, but also allow them to sort of be able to identify it through a testing algorithm that works. So I think movement is happening in this direction, but it just highlights the importance of strategies where not only can you sort of solve for increasing clinical awareness, but like the technology can catch us up as well.
Yeah, and certainly
Thanks,
at least, from that report, we saw recently that amongst the cisgender women who were diagnosed with MPOX, there was delay in diagnosis and it was mistaken for another STI. So it really highlights exactly what you're saying, Dimitri. We have only
I really love the article. It's so important to keep it. I mean, we worked so hard at the beginning to try to make sure that we said anyone can get it, keep your eyes out. But I think that as sort of this marches along, this is the perfect time to remember again that anyone can get MPOX, even though the majority of the cases are in gay, bisexual, other men who have sex with men. Sorry to interrupt you.
Yeah, I think we have two minutes, and what I want is just a very quick question, and I'll for the same question for both of you. And we have a lot of our audience are students, public health students. If there's one thing you would advise them to do as they continue their education and as they begin their career in public health, maybe what would that be? The one important thing to keep in mind. And I'll start with you, Deborah.
I would love for, we are the people that we've been looking for. And, we've got some of the best students going into public health these days. What I would ask them to do, or my recommendation, would be to advocate for something. If you don't stand for something, you'll fall for anything. Advocate wherever that passion is that you have. Advocate in that area of public health and move the needle forward for the communities that are most in need. Thank
you, Deborah. How about for you, Dimitri? What would you advise our young students?
So I first ditto with what Deborah said. I'll start by that, which I think really that like when you may start with one mission, but then things will change. But the thing that brought you to that mission will be things that you carry into other spaces. So you may start with HIV, and then next thing you know, it may be something about reproductive health, or it could be about smoking, but the lessons that you've learned, you carry with you, which leads to what my thing is, which is that public health is not just about your brain, it's also about your heart. And so it is okay to be tender, and it is okay to be vulnerable when you work with communities and really listen to what they have to say, because your superpower is to be able to empathize with their experience and bring that inside, and then blend that empathy and experience with the data that you see to create programs that respond to what they need as opposed to what we think they need.
Thank you, Dimitri.
That's why I love both of you, Wafa and Dimitri, for that answer.
Well, we love you back. I love you back.
I think there's no better way for us to end this webinar than with this remarkable advice from two amazing public health leaders and leaders overall in the arena of public health, and two people who have demonstrated exactly what they just described: the passion and the commitment to advancing the health and well-being of all communities. I want to thank you very much, Deborah and Dimitri, for joining us today. I want to thank all of you who joined us and all the people who made this webinar happen. So thank you very much and stay tuned to our next webinar. Have a good
Thank
day.
you, Wafa.
Happy
Bye-bye.
Thanksgiving, everybody. Thank
Bye-bye.
you.